And I'm happy to see quite a good turnout. I hope that my title of Geriatric Pharmacoepidemiology was exciting to you, and perhaps this will be a good opportunity for us to identify some areas of synergy and potential collaboration, both in research, but also in building the epidemiology and public health infrastructure here in the state. So my plan is to talk a little bit about what my field is, which is geriatric pharmacoepidemiology, particularly during the COVID-19 pandemic, and then also share with you some of my plans and ideas that I'd like to pursue as a new faculty member in the College of Health Sciences at UD. So we're going to kick us off here with just a brief about me so you can learn more about my path. I'll give everyone a brief primer on geriatric pharmacoepidemiology, just so we're all on the same page. I'm going to unfortunately bring us back to the COVID era briefly, just to see a little bit about, just to recall a little bit about why I focus on older adults for this disease. And then I'll take you through two studies that I had done prior to coming to UD that focused on the effects of COVID-19 vaccination in older adults. And then I'll summarize with some plans for the university, but also the state at large. So prior to coming to the University of Delaware, I was a senior research scientist at Brown. I was helping to lead a large U54 funded by the NIA that was broadly interested in building capacity to do pragmatic clinical trials among older adults with dementia. And my particular piece of that work was to lead a program of work that assessed the safety and effectiveness of COVID-19 vaccines in older adults. So that's where I kind of merged my background in pharmacoepidemiology and infectious diseases, and now that has really informed a lot of my work that I'm doing as faculty now. But prior to that, I did my PhD in epidemiology at the University of Toronto, where I focused in pharmacoepidemiology, but also in artificial intelligence and data science. So I have also an interest in kind of applying more novel analytic strategies to questions in public health. And then I did a tour of the Northeast US prior to that for my other degrees. So at UD, I currently have two active funded grants. The first is an industry-funded grant that examines the effects of the herpes zoster vaccine on dementia risk in nursing home residents. And we're applying a little bit more of an innovative causal inference approach called the target trial to basically use real-world data and emulate what a trial would look like using real-world data. And we have a bolus of nursing home electronic health record data to do this study. So we have access to 3.5 million nursing home EHRs for this particular study. The second active grant is an R01 that is examining significant drug-drug interactions among nursing home residents. So we're looking at pairs and triplets of drugs that are commonly prescribed among nursing home residents to try to assess their causal effects on various health outcomes. And then speaking of INBRE, I actually submitted a proposal to INBRE to do a 2-year project on cannabis and cannabinoid use in nursing home residents. And this is a mixed method study that I've put in with my colleague, Dr. Yanda Coffey, to basically build the foundation to do a future R01 on the comparative safety and effectiveness of these sorts of drugs in older adults. So here's this brief primer on geriatric pharmacoepidemiology. This as a field is basically the marriage of clinical pharmacology, so the kind of the study of drugs and vaccines in people, and epidemiology, which is kind of looking at the effects of exposures in large populations. So pharmacoepidemiology as a field is predominantly interested in studying the use, safety, and effectiveness of drugs and vaccines in large populations of people. And the geriatric focus is among those 65 years and older, usually. And really, what the goal of pharmacoepidemiology is to use observational data. So that would be data collected through Medicare claims, for example, is a common database I use, electronic health records, laboratory data, to ask a series of questions that are both descriptive, so understanding how drugs and vaccines are distributed throughout populations, but also causal in nature, trying to understand the causal effects of drugs and vaccines using observational data, which poses a number of unique methodological challenges. I'll just say that I work with a number of pharmacoepidemiologists who also do trials. So they'll conduct randomized trials of drugs and vaccines. but then also kind of marry the trial design with observational design by using health services data to collect outcomes. So I have colleagues at Sanofi who do these large pragmatic clinical trials that randomize folks to receive high dose versus standard dose flu vaccine, and then they use the health system to then collect those outcomes. So as a scientist, I'm very interested in the use of health administrative data, both in purely observational research, but also in trials to see how can we then maybe use observational data for outcome assessment and collection. And then for people who are interested in pharmacoepi, I'm teaching a course next spring in the College of Health Sciences. If you are interested, or if you have students who are interested, please feel free to get them in touch with me to learn more about what this course is going to go through. So here's the brief primer on COVID. We all, went through it, so I'm not going to spend too much time here, but older adults were probably the one group who experienced the greatest risk of morbidity and mortality when it came to COVID-19. The CDC estimates these huge numbers of relative risk, where adults 80 years and older were 340 times more likely to die from COVID compared to younger adults, which is just extraordinary. And on the plot on the right, I show you the case fatality rates plotted by age, and you can see that the case fatality rate was exceptionally low for folks who were younger and got COVID. But as we get older, the case fatality rates can approach upwards of 30%, which is, again, just extraordinary. And in the nursing home setting, COVID was particularly lethal. A number of attributed deaths were far outsized in the nursing home setting, in part because folks are older in long-term care, but also because people who live in long-term care generally have greater morbidity, right? So they have more chronic conditions, and that also increased their risk of adverse events. So older adults and persons with chronic conditions were therefore prioritized for vaccination against COVID. And older adults and people with multimorbidity are always recommended to get other sorts of vaccines like the influenza vaccine, given their increased risk. So this prompted us to then conduct a series of studies related to COVID-19 vaccinations in older adults. And we, I think, published 8 to 10 studies over the course of 2 years, using from this U54 that I mentioned that I managed. I'm going to focus on 2 just to give you a little bit of a flavor of what my interests are and kind of what we found using large health administrative data in the US. And so the first study I'll take us through is really asked what the comparative safety and effectiveness profiles were for the mRNA vaccines among older adults. And this study also examined variation, and in terms of, if we're talking like epidemiologists, it would be effect measure modification by frailty status. So does the effects and the profile of these vaccines differ based off of how frail you are? That was this first study. And then the second study was more descriptive. It was interested in using these health administrative databases to understand who's getting co-administered with the COVID and the flu shot at the same visit. And are there differences in who's getting co-administered versus not based off of their clinical characteristics? For example, whether or not someone has cancer or dementia diagnosis, and also where you live. So if you're in a more rural region or a more urban region in the US. So I'll be taking us through kind of this blitzed high-level summary of these 2 studies, and I'm happy to address questions at the end should some come up. But just a quick note on the data sources. So we had an interesting opportunity to collaborate with CVS and Walgreens pharmacies, where basically they gave us access to their pharmacy data. And anyone who had visited the CVS or Walgreens pharmacy and had a prescription paid for by Medicare, we were able to link those records to Medicare claims. So I walked into the pharmacy and I got a prescription for lisinopril, and Medicare paid for it. My record could then be linked to the broader environment and universe of Medicare claims. And so this includes Part A, hospital; Part B, outpatient; Part C is that Medicare Advantage plan; and then Part D is drugs. So the resulting cohort included about 37 million individuals. And this is about 75% of the US Medicare population. So it really is probably the largest population of Medicare beneficiaries that's been done to date. And what we were then able to do is we had these weekly records on all these 37 million people back from 2017, where we could where we knew each week what someone's history of chronic conditions were each week, and that then updated. And then we also knew whether certain health events happened. So if someone went to the hospital for a stroke, or they had an outpatient physician diagnosis for Guillain-Barré or long COVID, we were also able to see how those things changed over time down to the date. And in cases where there were health administrative data algorithms to help improve the sensitivity and specificity of these outcomes, we used those. If you're interested in learning more about the database, I've included the kind of cohort profile off on the right. We called the cohort COVAX age. And if you are an NIA-funded study, you can actually use this database for free. So the first study, as I mentioned, is looking at the comparative safety and effectiveness of the mRNA vaccines for COVID-19. And we used this large database of Medicare claims to do this. And we were operating within a causal framework here. So what I mean by this is that we wanted to estimate the causal effect of receiving Pfizer as a dose 1 versus Moderna as a dose 1 among older adults. Our index date, or time 0, for this study was the date that the first dose was administered. And then we looked forward 28 days from that date to assess for health outcomes. And we had 12 safety outcomes in this study, including heart attack, hemorrhagic stroke, non-hemorrhagic stroke, myocarditis, pulmonary embolism, Guillain-Barré. There were a whole list of outcomes that were identified in part through FDA concerns back in the day, but also our own kind of clinical team kind of came up with some questions about health outcomes that we should assess. We also assessed COVID-19 diagnoses as our effectiveness outcome. And we used several negative control outcomes as a way to kind of bolster our causal inferences. So we also used the claims to assess whether there was a difference in fracture risk, for example. And I'm happy to talk about negative control outcomes a little bit more if there are questions. But we ended up having a cohort of about 3.4 million people who were given a dose 1 of Pfizer, and about 3 million people who were given a Moderna. And we then compared these two vaccines head to head. So in terms of the key results, I'll just highlight that what we found was there was a small reduced risk of pulmonary embolism in people who received the Moderna vaccine, which was interesting. And we were concerned that, is this a safety difference? For example, is the Pfizer vaccine kind of causing an increased risk of pulmonary embolism in older adults? But we did some further digging into the data, and what we found is that the Moderna vaccine was a more effective vaccine by quite a large margin. So older adults who received the Moderna vaccine had about in terms of this estimate here, about a 15% reduced risk of COVID-19 compared to older adults who received the Pfizer vaccine. And they had about a 20% reduced risk of getting a COVID-19 diagnosis and a pulmonary embolism diagnosis. So what we kind of observed through this study is that if you receive a more effective vaccine, it also not only prevents the disease, but it prevents all the downstream sequelae of that disease. So COVID is known to cause pulmonary embolism. So if I can prevent a COVID, I can then prevent those subsequent cases of pulmonary embolism. So what was nice about this study is that we not only identified a difference in effectiveness, but the potential impact of that improved effectiveness on other downstream major health events like pulmonary embolism, for example. So, and for this study, we found that the Moderna vaccine was more effective, and it was not only more effective against disease, but also all the other bad stuff that happens after. And at the population level, this actually ended up being a large number of reduced events, so actual events. So this is our first paper. Again, this is a very fast overview. So if you have questions, I'm happy to take them at the end. The second paper I talked about, we're no longer in this causal framework. We're now thinking more descriptively. And this study was interested in using these health administrative data to look at the distribution of COVID-19 and influenza vaccine co-administration. So our population here was individuals who were receiving a COVID-19 vaccine. So people who are going to a CVS pharmacy or going to their doctor's office to receive a COVID vaccine. We then wanted to look at various clinical strata, so whether or not people had a diagnosis of dementia or cancer, or they have an immune history, like an immune disorder history, whether they were male, female, their age bands, and where they lived as of that vaccination. And then our main outcome variable is whether or not they got a flu shot at the same day. So it was a binary outcome. And in this study, we looked at 2 periods of time. So we looked at the kind of folks who got COVID, the COVID vaccine in 2021, and then we also looked at them in 2022 to see if there was a change in the rates of vaccine co-administration also over time. So in the 2021 period, we had about 6.3 million people who received a COVID-19 vaccine. Among them, almost 90% received it by itself. They didn't receive a flu shot on the same day. And then about 11% received a flu shot on the same day. But what we see is actually enormous variation, especially over time. So between 2021 and 2022, the rates of co-administration increased quite substantially from 11% to 36%. We also saw some interesting variation around who was more likely or less likely to get co-administered. So patients with dementia were significantly more likely to get co-administered than people without dementia, while patients with cancer and immune disorders were less likely to be co-administered. And we also observed really large geographic variation in patterns of co-administration over time. So here's a graph of the United States. On the left, we have the early period, the 2021 period, where the deeper the red color is, the greater the co-administration is. And then here on the right, we have the same outcome, but in 2022. So the most striking change is you can clearly see there's been an increase over time just about everywhere in the United States in rates of co-administration. So this is pretty good. The CDC now recommends people to get co-administered. So we're seeing an increase in that recommendation. But you can see pretty interesting variation across the United States. And what we found unique was that rates of co-administration were actually greater in more rural areas. And this likely tracks with people that wanted to go to the doctor's office more than once. And we do still see, although there's been this large increase in co-administration in the United States, we do see some variation, especially in Pennsylvania, which is interesting. Some people are less willing to get co-administered here. We actually remade this plot on a different scale to help show variation in the actual study at this higher rate of utilization. But nonetheless, I think this helps to show the power of health administrative data to ask big questions like this one. So really what I'd like to do at the University of Delaware is to grow capacity for conducting claims-based research. So I'm particularly keen to not only continue using Medicare claims, but also gain access to the Delaware Health Information Network and to potentially link cohorts that are already housed here at the university to the DIN to ask kind of claims-based information and health services information on data that are being collected regularly. I have plans to submit a number of our series grants to the NIA and NIDA related to drug use, safety, and effectiveness in older adults, especially persons who live in long-term care. And along with my colleagues in the program, I'm very excited to help grow our PhD program in EPI. And I think that there are a number of active research scientists at Nemours and at Christiana who are leading large research programs. And my dream, I think, would be to have them act as primary supervisors and have their students go through our program in epidemiology. And my goal, right, is to kind of build a little bit more of a network and connection between the department, but also folks at the hospitals. And I know that there are some folks here on this call, like Dr. Claudine Jerkovitz, for example, who does a lot of amazing epi work at Christiana. I think building these sorts of connections is something that I'm really motivated to do as new faculty. So that concludes